In this video, I will go over the clinical presentations as well as the treatment options for seronegative spondyloarthritis, all of which are presenting with arthritis but are negative for the rheumatoid factor, and they are usually associated with HLA-B27 antigen, and then the extra-articular manifestations include uveitis, which could include the inflammation of the iris. Now, the mnemonic that you can use to memorize these conditions is PAIR, and P stands for psoriatic arthritis, A for ankylosing spondylosis, I for inflammatory bowel disease, and then finally R for reactive arthritis. So psoriatic arthritis is seen in 30% of patients with psoriasis. And psoriasis, you may recall, presents with silverly stained plaques that's shown in this image. And then it's due to the thickening of stratum corneum and thinning of stratum granulosum. And then the treatment for the skin lesion is usually corticosteroids, vitamin D, or retinoids. Anyway, back to the topic. Patients with psoriatic arthritis usually present with stiffness, and then they have dactylitis, which is thickening of the fingers that has a sausage finger appearance. And then X-ray of these patients will show pencil in cup appearance of the fingers. So here is an image of a patient with psoriatic arthritis. So you can see that there is a sausage finger shown here, and then X-ray of the bones shows pencil in cup appearance. The next condition is the ankylosing spondylosis, which is usually causing low back pain and stiffness in young individuals. And it's due to the fusion of the spine at the sacroiliac joints. And classic presentations are bamboo spine. And then finally, due to the aortitis-mediated dilation of the aortic root, these patients also present with aortic regurgitation. So here is an example of a bamboo spine. So you can see that these patients usually have a back that is bent, and then due to the calcifications of the longitudinal ligaments, here is the calcification that you see. It's referred to as bamboo spine. The next condition is inflammatory bowel disease, and these include the Crohn's disease and ulcerative colitis. And then finally, we have reactive arthritis, also known as Reiter's syndrome. And the mnemonic that you can use for clinical presentations is cannot see, cannot pee, and cannot climb a tree. So these patients present with conjunctivitis, urethritis, as well as arthritis. So cannot see, cannot pee, and cannot climb a tree. And usually factors that trigger reactive arthritis include the chlamydia infection or GI infections like Yersinia, Salmonella, Shigella, or Campylobacter. So any of these GI infections or chlamydia infection may trigger the reactive arthritis. And then the treatment of arthritis is usually NSAIDs. And if the patient has chlamydia, you have to provide antibiotics. So here I would like to now go over the treatment options for the other conditions that I've listed here. So PAIR was the mnemonic. So for psoriatic arthritis as well as the ankylosing spondylosis, the treatment is targeted at suppressing the TNF-alpha or tumor necrosis factor alpha. And the medications that can be used include the infliximab or adalimumab, which are the immunoglobulins that are made against the TNF-alpha. And then there is one other medication called etanercept, which is made by the recombinant DNA technology. So what they do is that, you know how the immunoglobulin is made of the heavy chain, light chain, and then here is called the Fc portion of the immunoglobulin. So for the construction of etanercepts, scientists have connected the Fc portion of the IgG DNA with the receptors for the TNF-alpha. So once this gene is expressed, it will form a new structures that has the Fc portion of IgG and then the TNF-alpha receptor. So it's kind of the same as the antibody structure shown here, except that the TNF-alpha receptors is used instead of the antigen binding elements of the immunoglobulin. And then this etanercept can be used for the treatment of either psoriatic arthritis or ankylosing spondylitis. Reiter's, I just reviewed it with you. You can treat that with NSAIDs or if antibiotics is needed for the treatment of chlamydia. And then finally, we have the inflammatory bowel disease. For Crohn's disease, you can treat these patients with corticosteroids, with immune modulators like methotrexate or azathioprine, and then finally you can treat them with infliximab or adalimumab. For ulcerative colitis, the treatment is slightly different, and it's because the efficiency of some drugs is more with ulcerative colitis compared to Crohn's disease. So instead of corticosteroids, you can use the 5-aminosalicylic acid derivatives, which are the same structure as aspirin. And these medications include sulfasalazine as well as the mesalamine. And so these medications, how they work is that they destroy the lining of the GI tract, as a consequence of which it decreases the interaction of the gut cells with the immune cells. These medications also decrease the inflammation and are thus helpful for the treatment of ulcerative colitis. As for the immune modulators, methotrexate has not been shown to be very efficient in ulcerative colitis, and there are mixed results. So therefore, you have to either treat them with azathioprine or 6-mercaptopurine. And then you can also use infliximab and adalimumab in patients with ulcerative colitis. And then finally, since ulcerative colitis is only affecting the colon, you can just remove the colon in these patients to treat them. And that concludes our discussion.